All right. Last but not least, so it's not often that you get to introduce your one of your mentors and lab gurus who kind of helped me in my career. So this is a pleasure to introduce Dr. Frederick Goldman. He is a professor emeritus of pediatrics at Children's of Alabama and the University of Alabama in Birmingham. He currently is a member and previous director of the Pediatric Blood and Marrow Transplantation Program at UAB. He is a senior scientist in the Immunology and Cancer Immunotherapeutics program at UAB Comprehensive Cancer Center. He has published extensively on pediatric bone marrow failure disorders, including novel gene therapy approaches, and has extensive clinical experience in treating this unique patient population. So thank you for coming. He actually trained at LSU and Tulane, so you're one of us, right? and yeah, let me get your presentation here. All right.
Okay, thank you. Thank you for all sticking around here. You know, I know some of you probably hungry for some crawfish, right? It's what's on your mind. But, you know, I'm going to talk to you today about something that you may have never heard about. But I guarantee, okay, because I'm from Louisiana, I guarantee that some of these things are going to make you think. And you're going to go, oh, shoot, I did have a patient that had that, and I didn't know what it was. So this is a little bit of education to the adult world here because, you know, I'm a pediatric doctor, an oncologist, and a hematologist. And so my perspective is usually from that end. But I can understand what it would be like to be in the older group patient population and sort of see something you've never seen before. Then you don't even know what to call it. So I'm going to tell you about my journey here, and it's some cool stories. I hope that you're going to be amused at least, and I'm going to share with you some personal experiences and a little bit of science, okay? To start off, I do have a few disclosures. I'm a speaker for a few of these companies here, and let me tell you how come I'm here today. Because I was walking down the street, if anybody knows where that is, I was walking down the street about 6 o'clock San Miguel de Allende, and I just bought a house there, and I get a phone call from Corey Falcon. And by the way, thank you, Corey, for calling me here. But I'm going, Corey, I haven't talked in years. You know, why are you calling me? He goes, Fred, man, I'm desperate, man. I need a speaker. And I go, really? And then he talked, and I said, okay, I'm happy to do that. But this is the real live picture that I said, Corey, I'm going to take a picture as a momentum for you calling me. So thank you, Corey. And again, let me just also say thank you for inviting me and for being a great fellow with us and being a good learner. And this is the reason I do this, right? I think we all are in medicine because we like to pass on our knowledge, and Corey's a good example of how that really has evolved. And thank the sponsors and everybody else that's still here. So, to start off with the talk, what is MDS? Myelodysplastic syndrome. Okay, it is a clonal hematopoietic disorder or neoplasm. Okay, and what I'm going to concentrate on is the inherited bone marrow failure syndrome component of that, because it's due to a lot of other things. And in fact, if you're an adult hematologist, oncologist, you're going to say, I see that all the time. It's not inherited, and I know what it's due to. It's just old age. And that is, you know, that's true. But in my eyes, you know, we don't see it that often in pediatrics. But what we do is how we diagnose it is we look in the bone marrow, and you're going to see morphological changes of what we call dysplasia. And 10% of the cells that in the marrow will all be sort of funny looking or dysplastic. And when you have funny looking bone marrow stem cells, that usually results in bad production of red blood cells, white blood cells, and platelets. And so you're often going to see cytopenia in the peripheral blood. And this is also, in our setting, going to lead to an increased risk of developing leukemia. And I'm going to tell you why. Okay? Now, pediatric and adult MDS are completely different. So whatever you adult doctors know about MDS, it's not the same in pediatrics, okay? It's not at all. And I'm going to show you some of the differences. First of all, it's about 50 times more popular or common in adults. It presents completely differently. Okay, and the reason is because it's usually a disease of old age in adults, and in pediatrics, it's usually a disease related to some underlying genetic mutation, when we're going to call that a bone marrow failure syndrome. The exam is also unique because in a syndrome, think about syndromes, there's usually physical anomalies associated with that, and that's what we would see if we do a good exam on our patients, and that's the point. Do a good exam because you're going to see a case where I didn't. And then, you know, the cytogenetic abnormalities are pretty unique. There's a 7q or monosomy 7 is much more common in the pediatric patient population, whereas the 5q minus is much, much more common in adults. we used to use the old terms like rabbit T, and so on. We don't do that anymore in pediatrics. We're finally got smart and made it simple. You're either childhood MDS with low blast or childhood with a high blast. It makes it easier for me to remember the categories. And that excludes some of these other things here at the bottom. And that's different than adults, where you guys talk about low risk and high risk and this and that. I don't want to even try to remember that. But in pediatrics, it's just that, okay? And now I want to talk about how to diagnose this. How do we diagnose a really, really rare disease? Well, first of all, you have to distinguish it from a disease where you don't make bone marrow, which is called aplastic anemia. And so think about, how does bone marrow grow? You've got a stem cell, a hematopoietic stem cell. You've got your soil or your niche that the cells are growing in, and then they make a garden. And that picture here on your left is, or I guess it's on your right, what that garden is that's a picture of bone marrow. Okay, it's very cellular. And if you were to look at each of these individual cells, they'd be the cells that make platelets, red cells, and white cells. But what happens is, in this aplastic anemia or MDS sometimes, you have an ineffective network here. You either have a defect in your stem cell or defect in your niche, and you just don't make anything. And that picture there now is what aplastic anemia would look like. There's no cells in there, okay? Now, it could either be what we call idiopathic. Do you know what the word idiopathic means? It means you're an idiot. As I always say, it means you're an idiot. You haven't figured it out, okay? There's no such thing as idiopathic. It just means you don't know what it is yet. That's right. As a first-year fellow, I said, and then now he's no longer that. But so we have to distinguish idiopathic aplastic anemia from something else that might have a genetic cause. And so what we're going to do is concentrate on what I call the inherited or genetic components of this. So how do we diagnose it? That's the first and most important point. Okay. Well, the peripheral blood counts give you a clue. If somebody presents with a low blood count, you're going to be thinking, is there something wrong with the marrow? And if they're really low, like we have here, platelets less than 30 and an ANC less than 500, that would be categorized as severe. And then you're going to say, okay, we got to do a bone marrow exam. And the bone marrow exam is going to usually be low cell numbers, like that picture I just showed you, with a very kind of, what is that? We use the word Swiss cheese appearance, where there's no cells in there. Okay, so if there's normal looking cells, that might be a hint versus if they're very dysplastic. Okay, so you have to look at that to get clues. And another clue is, what do the red cells look like? Are they big? If there's a high MCV, if they're really big red cells, that might be a clue that this is an inherited or genetic cause versus the idiopathic or immune-mediated phenomenon. Okay, and is the hemoglobin F increased? Is the blood counts suddenly go down, or is it slowly going down? All these things are clues for us. Okay, and then another thing is, what is about the clinical presentation? How about the physical examination? I already told you that sometimes the physical exam can be very, very important. Now, a lot of doctors here, we don't believe in physical exams because we've got blood tests. We've got radiology, right? But the physical exam is still something that we should have learned in medical school, okay? And so same with the history. You should really take a good history and do a good physical exam because they can give you clues. A birth history, a family history. These are all things that are going to direct you to whether or not this might be an inherited genetic part. Okay, and then of course look at the skin, look at the skeleton, look at these different features that are associated with some of the syndromes that I'm going to talk about. Okay, and it's really, really nice if the patient fits the textbook pictures, because you know what? We read textbooks and we look at the picture and we say, okay, does that match? Yeah, okay, good. If it does, right on. And so here's the textbook picture of Fanconi anemia, right? Anybody remember this picture? It is straight out of the textbook, okay? Nelson's Pediatrics. Fanconi anemia. I bet you most of the people in the room know that. It's not that rare of a disease. Discovered in 1927 by Dr. Fanconi. It has certain diagnostic features. Okay, it's often associated with short stature, some neurological impairment, skeleton anomalies, et cetera. You can read all those things right there. Average age of diagnosis is 7, but I've had plenty of patients that have been diagnosed as 20-year-olds because they have a milder phenotype, which is known to exist. This is a cancer predisposition syndrome. The reason adults need to know about this is you're going to see these patients and they're going to present to you with a sarcoma or an adenocarcinoma or something because they have a 700-fold increased incidence of squamous cell and a 5,000-fold increased incidence of leukemia. And so if they live old enough to see the adult world, they will actually be seeing the oncologist. And this disease is manifest, and the reason this disease even exists is because every mutation in there is related to DNA repair. So this is the disease of DNA repair, okay? Now, Shwachman-Diamond syndrome. I'm going to review just a few of the marrow failure syndromes. I'm not going to review them all for you, but I think the most relevant ones for y'all. Shwachman-Diamond syndrome, SDS. Now, they forgot to put in the guy Boudin, who was also one of the people. It almost sounds like Boudin, but Boudin, okay? It's now called SBDS syndrome because they forgot to include him. But this was first described in 1964, and it's an autosomal recessive disorder characterized by what we call the clinical triad of pancreatic insufficiency, skeletal anomalies, and intermittent neutropenia. But you know, a lot of the patients don't present that way, and the pancreatic function is bad initially, and then people outgrow that. Not everybody has a textbook picture. That picture right there of that little baby is one of my babies that I took care of that did a transplant on. The diapers at the bottom to show that she had increased stooling and such, but nobody could figure her out because she wasn't quote unquote typical. Okay, and I had to kind of for me to make that diagnosis before the genetics was known was a cytoskeletal test that we did back in that day. But I'm not going to go into that. But I'm going to tell you it's a rare disease. The adults might not see this too often. But here's the one. If there's a take-home point for today, it's be aware of this disease. Raise your hand if you have heard of dyskeratosis congenita. Good, okay? Half the people have. Now, this was described as an X-linked disease in early 1900s. Okay, so it had been around for 100 years or so, and it has the classic triad of dyspigmentation, leukoplakia, and what we call dyskeratotic nails. And you can see the nails on the picture over there are sort of absent. That's the classical triad. So these patients are known to have a very high risk of developing aplastic anemia. In fact, if they live old enough, that diagram on the lower right-hand panel there shows you that everybody gets aplastic anemia. But they also have a super high incidence of developing MDS and AML. Okay, but we now recognize this is a systemic disorder. And so here's the story. In 2 slides, I'm going to tell you the story about dyskeratosis. So sometimes we can't just diagnose on a physical exam. We need additional testing, okay? And so some of this additional testing to make a diagnosis, today, the modern world is we can do a genetic test for everything. But there's also functional tests that we can do for some of these disorders. And so the functional test for Fanconi anemia is, what did I tell you it was due to? It was a DNA repair defect. Well, you can expose cells to agents that are DNA damaging agents like mitomycin C or DEB. And when you expose cells to that, their chromosomes break up and they form tetramers or they form little breakages. You can actually quantitate that and look under a microscope, like you see there on the diagram at the very far left or far right, excuse me. And this is a diagnostic tool. We've used this forever to making an FA diagnosis. So they have an increased sensitivity to DNA agents, or sorry, DNA alkylating agents. This is a clue because we didn't think about this, but if you start treating patients with drugs like this, they're going to have an increased sensitivity. But again, that's for our next slide. But in dyskeratosis congenita, this is actually a disorder of telomere attrition. Telomeres get shorter. And we now have a way to measure telomeres. And telomeres, for those of you that don't know it, that's the end of your chromosome. And if you think about it, it's kind of like a shoestring. Okay, and what's at the end of your shoestring? Plastic. Because if you didn't have that plastic there, they would unravel, right? Well, the telomeres, every time your cell replicates, the DNA has to open up, right? That's how DNA replicates. It has to become single strands, and then it becomes double strands. Each one of those, that's how you replicate. That's mitosis. But in the process of replicating, there's always an end that's exposed. And you see that end right there. Well, that end would normally fold over on itself like this to protect itself from degradation. Every time the cell replicates, it's exposed. Every time the cell replicates, every cell division, there's going to be the shortening of the telomere naturally. Do you want to know why you can't live to be 200? Your cells can't replicate that long. Telomeres, the Hayflick principle determines how long your cells will replicate. Most cells only replicate about 50 times, okay? So we know that if you don't have that telomere intact, you're going to be digesting it away. And what we can do now is measure the telomere length, and you sort of see that graphic right there, that over time your telomeres are going to get shorter and shorter and shorter. Okay, they start out at 15 kb. This is measured by flowfish, by the way, and they get shorter over time. The red dots there in that graph are reflecting patients that have dyskeratosis congenita, and you can see that they have very, very short telomeres, right? They're not going to live as long as somebody that has normal length telomeres because their cells won't replicate. Their bone marrow will fail. They will develop leukemia, as you're going to see the picture, okay? So case number one. I always love to give examples of things to learn because you know what? This was a major learning experience for me. I remember the day the mom came into my clinic and said, Dr. Fred, she always called me Dr. Fred, never Goldman, Dr. Fred, you've got to treat my kid. My family is dropping like flies. She used the word dropping like flies. She goes, Uncle Joe just died. And so here's the family tree. You see the family tree there? And I kind of outlined them in blue and yellow and such. But she describes to me a family where multiple family members have low blood counts and myelodysplastic syndrome, and on top of that, there's women and men in that family history. So y'all geneticists, you're thinking, that sounds like it's maybe autosomal dominant, okay? But I'm looking at the patient, and I didn't look at him that closely. I didn't take the shoes off, and I didn't know what he had. I actually, I'm going to be honest, I did not make the diagnosis initially. I had a colleague help me who said, did you take off the shoes, Fred? I go, no. He said, you should have. Then you'd have seen those dyskeratotic nails. So he says, your patient's got dyskeratosis congenita. And I said, no, he doesn't. Look at the family tree. That's not X-linked. I just told you before, dyskeratosis is X-linked disorder. You can't have that with girls in the family. And so I was at a meeting just like this. I swear, this all happened within a couple of months. I'm at a meeting called ASPHO, American Society of Peds Hemonc in New Orleans. And I meet Dr. Dokel, who is the guy that actually described the X-linked form of dyskeratosis. He was giving a talk on dyskeratosis. And I went up to him and I go, Dr. Dokel, so fun to meet you. Finally, I got this patient that's got, it looks like it's dyskeratosis. And I'm all excited to talk to him. He's going, sounds familiar. I've got a couple of families like that too. And I said, what should we do? And then he says, well, why don't we do a study? And I said, okay. And so what we did was he said, bring all the patients from that family in to see me. And I'm like, wow, that sounds spooky, but okay. I literally got 100 people. This family was large. Look at how big it is, okay? My proband is the one in black, okay? There was about 10 people in what we call generation 3, but we traced them back, and I got uncles and aunts and so on and so forth. I got 100 people in clinic, and what we did was we looked at 100 people. We did a blood test on 100 people, and we determined whether they looked like they could have had dyskeratosis, that they had the skin, the anomalies. And the ones that looked like it were in black. Or if we did a blood count and they were low blood counts, we said, yeah, that means yes. We're going to put yes, they have the disease. If they maybe had it, we're going to put this kind of gray symbol. If they had no symptoms, if they had a normal exam, they were white. Okay? And so then we did a linkage study. For those of you who don't know what that is, that's an old-time fashioned way that we used to do genetic tests, make diagnosis of genetic diseases. So you take people's DNA from their blood and you run it on a southern blot, and you look to see if there's any mixing or matching similarities between one person versus the other. And what we did was we did that on all these 100 people, and we ended up finding it was an area on chromosome 3q26 that looked a little bit odd. And that was odd because some of the patients that we knew that had that had the clinical phenotype also had 2 bands, meaning that they had 2 transcripts, okay, which ultimately meant they had a 64 base pair deletion of what turned out to be the molecule right there, hTERC, T-E-R-C, telomerase RNA component. So this was the first description, which we published in Nature in 2001, the first description of autosomal dominant dyskeratosis congenita. Why is this important? It's important because, well, nobody thought dyskeratosis could exist in anything but males, and we never knew what to call this. And so now that sort of discovery led to me now being in the world of dyskeratosis and telomere biology. And so we determined a few things like disease anticipation. Subsequent generations will always get shorter telomeres because you're born with short telomeres. They're passed on in the gamete. In fact, this disease is going to burn out in this particular family. They can't have children, okay? They're infertile. I'm not wanting to say that too loud, but this disease will not be forever in that family. We also found out that these cells had an increased sensitivity to DNA damaging agents, much like Fanconi, and they had increased oxidative stress, and we published that. And then we also published, we collected hematopoietic stem cells by pheresis from 10 patients. And we looked at them and we found out that they had a very small number of what's called LTCIC, or true hematopoietic stem cells. They were lacking in these patients. Why do they develop bone marrow failure? It's because they don't have enough stem cells to sort of keep them going. They keep that garden in good shape. So we made quite a bit of observations from that one patient family. And so I'm just going to tell you that DC is a spectrum of human telomere disorders. We now call it telomere biology disorder, but the lesson I want you to know is that your patient might not develop myelodysplastic syndrome, but if you've got somebody with idiopathic pulmonary fibrosis, idiopathic, again, you heard that word, they probably have dyskeratosis congenita. You should probably be measuring their telomere length. Or if they've got hepatic fibrosis as another very, very common manifestation of dyskeratosis. So the point of it is this is a spectrum. They may not all manifest one way. They may not have marrow failure because the clinical phenotype correlates with the genetics oftentimes, but it's a tricky disease to make that diagnosis of. And now, today, fortunately, we've got genetics. But back when I was working on it, we didn't have easy sequencing. You know, the genome was discovered, the whole genome was sequenced back in like the late 1990s. But now we have the sequencing known for many of the important genes. There's 20,000 genes. We pretty much know the sequence, all of them. So if you want to know whether a patient has dyskeratosis congenita, you can sequence, you can do whole exome sequencing, and it's not hard to do. There's a bone marrow failure panel out there. I think Invitae does one. There's different companies that sell these different ways to make these diagnoses. Sometimes you'll find a VUS, variants of unknown significance. Is it or is it not pathogenic? That's something you have to sometimes work through. So, genetic testing is very powerful, and I highly, highly advocate it for that. And the nice thing about this meeting is I'm hearing the power of it in so many other areas, in MRD detection, in diagnostics, looking at for infections with the Carius test, and so on. So the power of sequencing is huge. So we know about MDS. Now we're going to kind of switch gears a little bit because this is a cancer conference, and I had to kind of come up with, all right, why do these patients develop myelodysplastic syndrome? Okay, and so same framework we talked about before about you got the stem cell that's healthy. Something happens to the stem cell. Some mutation happens. Okay, why does that happen? I don't know. Is it age related? Did these patients get exposed to radiation? Do they have some predisposition? Whatever. There's lots of reasons patients develop MDS, and I'm not going to talk so much about, again, the adults that develop it, but in our pediatric world, those genetic syndromes that we just mentioned, I'm gonna mention those. Okay, and so we know that if a patient with dyskeratosis or Fanconi, if they develop MDS, it's usually going to be around 10 to 20 years of age. It takes that long for the symptoms and for the pathology of the disease to manifest itself in the marrow and to eventually cause that dysplasia. But there are other syndromes, which again, I don't think a lot of us think about, and that's GATA2 and SAMDS9, okay? These are also MDS predisposition syndromes, really, really high incidence of MDS in them. Okay, so GATA2 was first described only about 15 years ago, and there's different syndromes that go along with it, but they are also associated with this immune deficiency and often pulmonary infections, and it's kind of a syndrome, but they don't look any different from a physical standpoint, but they certainly suffer from a spectrum of clinical problems that we're not used to seeing, recurrent pulmonary infections. Well, these patients have a tendency to develop monosomy 7 and trisomy 8, and it is autosomal dominant, so you may get a family history of this as well. And 7% of all MDS cases, in fact, are related to GATA2. So this is an absolute important disease to rule out when you have a patient that has monosomy 7 or has MDS. Similarly, SAMD9 or SAMD9L mutations can cause MDS, and they account for about 17% of MDS. So that's another important genetic disease to rule out. This syndrome was first described in 2016, so again, fairly new in our arsenal of things, our new diagnostic possibilities that we need to consider when we have a patient with MDS. And so again, this syndrome is autosomal dominant. You could get a family history from these patients, and they're associated with immune deficiencies and growth impairment. Now, in some cases, it's associated with a gain of function. So the mutation that you see as part of this disease gives you a phenomena where these cells are not effective in producing more stem cells, and they sort of become dysplastic, and ultimately these patients may have aplastic anemia that's confused. So, got to put that also in the differential. So, what about the risk? Now, this, to me, blows me away when I look at the Fanconi anemia risk. 5,669 times increased risk of developing MDS. So if we are lucky enough to have our Fanconi patients survive to adulthood, we've got to think that they're going to develop leukemia. And in fact, this is the reason we do what's called preemptive transplant on these patients. Oops, what did I do there? I went forward too fast. Sorry. So if a patient has Fanconi anemia and then they start developing some low blood counts, we are going to take them to transplant because we know if they don't, they're going to develop leukemia. And if they develop leukemia and then you try to transplant them, I got this slide. The next slide's going to show you that. Not good. So before they develop MDS, we need to think about doing something. Not really the same with dyskeratosis. I would not take them to transplant right away, but I'm just going to point out that their risk of myelodysplastic syndrome is 578-fold that above the average population, and Schwachman is about 200-fold increase. Why are these patients developing MDS? I pretty much told you to you already. They have repairs in DNA, their DNA damage repair defects. Even though some of the genes for these things, you might say, no, they're related to telomeres. Nah, but there's overlap in DNA damage repair. So we have to think about that and what to do moving forward. We have to also have that in our mind. So back to our original Iowa family. I got a phone call about 3 months ago. Uncle Bill, and it's not his real name, the one over there on the right hand or on your left hand side, they said, he just developed AML. What would you do? And I go, oh gosh, that's not a good thing. That's not a good thing to develop leukemia with this disease, because if you give chemotherapy to a patient that has a DNA damage repair defect, every cell of their body is not going to be able to tolerate that quote unquote damage. So this is a hard thing to do to get them into remission. So we did give them some recommendations, and I do know that I spoke with a transplanter out there in Iowa, and I gave them some thoughts. But you're going to see in the next slide how these patients do. And so here we are. I know these patients. I know I'm going to hear about each and every one of these in the next few years. And it's unfortunate because, that's just the disease. But we published an article down there on your lower right-hand panel about dyskeratosis in transplant. They don't do very well, and it says about 50% survival compared to about 95% survival for aplastic anemia. Why don't they do well? Because they've got underlying organ dysfunction to begin with. They're syndromic, and because, again, I told you about the DNA damage repair defect. Fanconi anemia, they actually do really well. You see the panel up on the top, they've got about a 95% survival now when we transplant them early and before they develop leukemia. If you transplant them when they have leukemia, it would be horrible. They have about 20% survival, if that. And same with Schwachman, that's the other one. Transplanting patients that have these bone marrow failure syndromes when they have active MDS or leukemia is not going to result in any terrifically good outcome. So, not to leave you in a depressed mood, but to say, hey, you know what? Times are changing. We need to be thinking about new things. And so these are some new exciting things. These are basically right hot off of the press because I did a lit search on this before I came here. I want to see what's out there. And we've been involved in some of these studies. Antioxidants, I've been working on antioxidants for years. Okay. Finally, I proposed studies that never really went anywhere, but finally somebody did one for Fanconi anemia with this drug called quercetin. I don't even know if I'm pronouncing it right. Preliminary data, phase 1 study, not terrific, but at least people are thinking about ways. These are systemic disorders. You can't just think about just treating their marrow because that's only part of it. So same thing with dyskeratosis, the bottom one. They've got this agent in there that they've actually gone in and they're trying to elongate the telomeres by a gene therapy approach, by putting in this protein called SCAN. And so using this, they're thinking that they're able to elongate telomeres in their hematopoietic stem cells and that maybe they'll live longer. Again, very preliminary results are not super encouraging, and but I want to say that you got to start somewhere. And then the Fanconi story, there's a clinical trial out there, Rocket Pharma. I think they are now FDA approved. The phase 1 study, phase 1/2 study was pretty good in the sense that it showed some improvement in blood counts. Is this going to be the end-all cure-all? I don't think we're there yet. But the point of it is that these are pretty bad diseases, and there are treatments out there. Will probably get better in 10 or 20 years. You know, the things that I've thought about, I'm glad to see is starting to manifest. People are starting to do some of these things. But I guess that's really all I have to say about MDS and these marrow failure syndromes. And I really appreciate y'all sticking around, waiting before I know your stomach is can't wait to get some of that crawfish in there, but I'm happy to answer any questions before y'all take off.
Great talk. I have a question. I have a family that I'm following with SAMDL9. And so the mom has it and she's in her 50s. She's fine. Right? Her daughter was transplanted at the age of 3 about 15 years ago. I'm following her son who's around 18. He had one episode of thrombocytopenia a couple of years ago. And then okay after that, seen in a couple institutions, one of which said go right to transplant. I'm not transplanting because everything's normal. So what are the recommendations for SAMDL9? Because it's changed over the last few years.
Yeah. I'm not going to, one thing I'm going to tell you is I'm not an expert in SAMD9. It's a rare disease, just kind of like I told you before, just kind of being understood as far as what the diagnostic criteria are. We found the mutation, but I would say I'm a country doc, and I'm from Louisiana too, so I like to think in a simple way. If it ain't broke, you don't fix it. If they're not that cytopenic, these syndromes, there's other things that can go along with it. It's not like you have to transplant them right away or they're going to develop leukemia. It's not like the Fanconi story, okay? Yeah. And so we've had some SAMD9s we've been sitting on as well. And I'm saying, I'm not so sure, unless if they've got transfusion-dependent aplastic anemia, I'm not so sure what the urgency is, but I would also say, don't take my word for that exactly. I mean, we've had these discussions. There's not a
Everyone I talk to has a different opinion. In general, people are saying probably not, because there's that paper came out about a year and a half ago about the kind of gene editing that happens with that, and you can kind of lose the clone, and it's like, oh, well, okay.
Yeah, right. There's a lot that needs to be learned still about that disease, so I can't tell you yet where we are today or where we will be. But I'm a little bit apprehensive to transplant these patients. Yeah.
Thanks for attending our
All right.